Good morning again. We will move to the next session of the patient blood management. And I will start to introduce our first speaker, Professor Sigismond Lasocki. Professor Lasocki is a French professor of anesthesiology and critical care medicine. He is the head of Angers Université Hospital Anesthesiology Department since 2013. He is part of the organizing committee for the Société Française d'Anesthésie Réanimation, the Committee of Nutrition and of Perioperative Medicine of the European Society of Critical Care, the representative for France at the European Society of Anesthesia and Internal Critical Care Council, and he is the scientific chair of the NETA. His areas of expertise are anemia and iron metabolism in critically ill and perioperative patients and trauma patients. So the mic is yours, Professor Lasocki.
Good morning, everyone. It's a great pleasure for me to do this talk about patient blood management. And first of all, I'd like to thank the organizers, and I'm very sorry not to be able to be with you in person, and I hope that I can come next year. So first of all, I want to share my conflict of interest. I received grants from iron industry and also erythropoietin industry. What is PBM and where do we come from? We come from the idea that a blood transfusion could be deleterious to patients, and of course in France we have this massive problem with HIV contamination of the blood banks, and the idea that we could reduce the blood transfusion to avoid this transmission of infection. In fact, transfusion risk is not only the risk of transmission of infectious disease, which is very low now, but it is about the risk of a lung injury with TRALI or TACO, the risk of mistaking the blood bags for the wrong patient, the products that could be deleterious to the organs or to the patients because of storage lesions, and all the immunomodulation which is bring by the transfusion with immunomodulation and the risk of infection or cancer recurrence. And of course, in the context of surgery, we have a high frequency of preoperative anemia. Around 30 to 40% of the patients have preoperative anemia, and this anemia is associated with longer lengths of stay, with increased infection rates, with increased kidney injuries, with increased death, but also obviously with an increased risk of being transfused. And this transfusion during our surgery is also associated with poorer outcomes, as it is shown in this large cohort study, around 10,000 non-cardiac major surgeries of patients being transfused with 1 or 2 units in absence of hemorrhage or bleedings. And as you can see here, the patient being transfused had a higher risk of sepsis complications, wound infection, pulmonary complications, and also an increased risk of mortality. So from that point comes the idea that you should promote PBM in order to avoid blood transfusion in those patients who have anemia prior to surgery. And the WHO had this decision more than almost 15 years ago already, to promote the quality and safety of blood products and to implement PBM in order to minimize the transfusion. So the first objective of PBM 10 or 15 years ago was to prevent avoidable transfusions. Then the recent years bring us the COVID-19, as you all know, of course. And in that context, we also experienced shortage in blood. And then blood management could be also a way to have adequate blood supply with less consumption of blood for surgery or for patients who could be treated prior to surgery. And this change of concepts is further, one step further. It is now, and that's why what I want to underline, the improvement of patients' outcome, much more than focus on product safety or product shortage. Indeed, if you look at the literature, you can see here that there is a huge increase in the PBM terms in the article published compared to the idea of just blood conservation or bloodless surgery. And this concept of PBM is now well defined. It is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. So it is much more to improve patients' outcome rather than to limit blood transfusion. And this definition is endorsed by all the PBM societies, including NATA, which is the European Society for PBM. And indeed, this comes also together with the idea of promoting ERAS protocols. And for example, in the recent guidelines on perioperative optimization protocol for adult patients, we had this recommendation that it is probably recommended to implement a patient blood management program in order to reduce the length of stay or the occurrence of postoperative complications. So again, PBM in order to promote a patient or to improve patients' outcome. And that's really, really what we do now with anesthesia and new surgeries, is to improve patients' outcomes. The three pillars of PBM are well known. It's the first one is to optimize hematopoiesis. The second is to minimize the blood loss and the bleedings. And the third is to improve the and optimize the tolerance of anemia. And so we have things to do for these three pillars in the three periods, the pre, the intra, and the post-operative periods. And it's come with iron and EPO for the optimized erythropoiesis. It is for the minimization of blood loss and bleedings. It's of course the surgery, the meticulous hemostasis and surgical techniques, but it is also the tranexamic acids. And then regarding the transfusion, it is to keep it very restrictive, and we will see all the data for that. We have now very recent recommendations. So we have this 2018 Frankfurt Consensus Conference on PBM, which is an international conference. And we have also a very recent last year publication of the HRS recommendation on PBM with three periods highlights. So I will now give you the most striking points for those coming from those recommendations. And for the pillar one, so the iron and the erythropoietin, it is recommended to detect preoperative anemia early enough and to use iron supplementation in case of iron deficiency anemia, and to use in the international conference erythropoietin plus iron in case of anemia in orthopedic surgery. In the French recommendation, it is recommended to have a systematic anemia and iron deficiency screening before surgery at risk of bleeding, or in case of fragility of the patients, to treat pre-op anemia, but anemia is defined as an hemoglobin below 13 for men and women. That's really new. To define iron deficiency anemia as a ferritin below 100 microgram per liter, or it is set below 20%, and to use IV iron. So this will be my next talk. To use erythropoietin in orthopedics and cardiac surgery. So cardiac surgery is new for systematic use, and to evaluate the benefit of erythropoietin in case of inflammatory anemia, or including cancer anemia. That's only an expert opinion. So why use the same value of hemoglobin for men and women when the WHO definition of anemia is an hemoglobin below 12 in women? In fact, if you look at thousands of data, for example, this cohort study from Austrian centers, you have the woman in red and the men in blue, and you can see that for the different surgeries, the women are at higher risk of being transfused compared to men every time. So it makes no sense to treat less the woman when they are more transfused, and obviously because the blood volume, the total blood volume of women is lower than men because they are smaller. The bleeding is quite the same, and so you have to increase more the hemoglobin in women for the same bleeding to avoid blood transfusion. And this is also the consensus we have published a few years ago. And the idea is that you have to look at the hemoglobin level prior to surgery in case of surgery at risk of bleeding, so transfusion risk higher than 10%, or blood loss higher than expected blood loss higher than 500 milliliters. And in case of hemoglobin lower than 13, then you have to postpone the surgery in order to treat the patient. The two main causes of anemia in these patients are iron deficiency and the anemia of inflammation. The first would be treated with iron, the second could need erythropoietin. In fact, when you look at the data with iron in the pre-op period, you can see here the most recent studies, and you have in blue the baseline hemoglobin, in red the hemoglobin after iron therapy, but before surgery. And you can see that it increases in all the studies, but it's really it is never higher than 13 grams per deciliter, which is the usual target to avoid blood transfusion. So if you want to avoid blood transfusion, you may need erythropoietin with iron, and this is the recommendation for orthopedic surgery. But in fact, in the meta-analysis, when you compare erythropoietin plus iron with iron alone, in this meta-analysis, you reduce the blood transfusion by more than 40%. And this is true for orthopedic, for cardiac surgery, and in the other surgery, including colorectal cancer surgery, the numbers are too low, and so there is not significant effect, but in total, it is, of course, significant. So the French recommendation say that in case of cardiac surgery or orthopedic surgery, you should use erythropoietin plus IV iron. For the other surgery, if you have iron deficiency, you treat it. We will see that in the next talk. But if you don't have iron deficiency, which is a ferritin higher than 100, and it is probably an anemia of inflammation with a TSAT below 20%, you should discuss the use of erythropoietin. And in fact, in case of anemia of inflammation, you should discuss the benefit of erythropoietin, because it is the only way to increase enough the hemoglobin to avoid blood transfusion. So for some patients, it could be very needed. And indeed, in other guidelines, including the American guidelines or the European guidelines, very recently updated in 2022. Both advocate the use of erythropoietin in absence of iron deficiency. So you may think that it is complicated to implement, and that your surgeon may be very unhappy because you will postpone some patients. In fact, when you look at the data, for example, this very recent cohort we had in France, with more than 2,000 patients, 1/3 had anemia. That means that 2/3 of the patients will not have anemia and will not be postponed. So the majority of the patients will not be postponed. And in France, it's only 30% or less than 30% of the patients that are treated for the moment. So we have room for improvement. And when we look at the delay of the usual delay between the anesthesia visit and the surgery, it is more than 3 weeks in median. So we should have the time to treat the patients without postponing them. And we have a lot of patients to treat. So maybe you will not treat all the patients, and maybe you will postpone 1 or 2 of them in order to treat them, but that will be useful. How you can do that? You may need to communicate, and it is absolutely needed to have a good communication between surgeons and anesthetists in order to schedule all this treatment of anemia. And you have to, for pillar 1, to define who will do the blood sample. Probably the surgeon could prescribe it. How you will do the IVR1 prior to surgery, who will do the control of hemoglobin, and most importantly, you need to evaluate your program in order to make the surgeon and all the teams involved showing benefits of what you do. In the perioperative periods, the idea is to limit the bleedings, and the most useful drug for that is the tranexamic acid. So very simple, 1 gram at incision, and in case of continuous bleeding, you may infuse 1 gram over 8 hours following this first bolus incision, or just do 1 more gram at skin closure. In case of hemorrhage, you do tranexamic acid. Of course, the surgeon has an important role in minimizing the bleedings. No tourniquet for knee surgery. The cell saver for cardiac surgery, aortic spine revision, but it could also be used and proposed in case of cancer. And this is an expert opinion, but with some data showing no increased risk of metastasis, notably if you use filters with the cell saver. Limit the drainage and normothermia during surgery. But just some data on tranexamic acid. You probably know this very recent POI3 study in all type of surgeries, non-cardiac surgeries. As you can see here, they used 1 gram at incision followed by 1 gram at skin closure, and they were able to reduce the bleeding by 25%, so very important. There is a fear of increased risk of thrombosis, and you have this very large meta-analysis of 216 RCTs in all the type of patients. And you can see here that there is no increased risk of thromboembolism when you combine together all this data, and for all type of surgery, there is no increased risk of thromboembolism. And on the opposite, there is a lower risk of bleeding mortality. So very, very no fear of tranexamic acid. It's very cheap and very useful. Regarding blood transfusion, we know that you have a lot of variability on transfusion triggers, but the recommendation is to keep it very restrictive. So an hemoglobin below 8 gram per deciliter or 7 in case of ICU. And the very more recent RBB guidelines also show the same, that is fewer blood transfusion with no increased risk of complication with restrictive transfusion. When you use that, remember to use the single unit policy, which is to give only 1 unit a time and to reevaluate the benefit or not of the blood transfusion without before giving a second unit. When you implement that, that's the Australian data, where they do it as law for the whole part of the country. They were able to reduce blood transfusion by 40%, to reduce mortality by 28%, and to save billions of dollars. So it's very, very important. And we did this medico-economic evaluation in France using 1 year data, so almost 1 billion patients for orthopedic, cardiac, vascular, thoracic, and neurovisceral surgeries. And we applied to this data a model including the cost of the treatment of all the anemic patients and the expected benefit with reduction in length of stay and blood transfusion. And the result is that we could save more than €1 billion from the national insurance perspective or the hospital perspectives, and more than 160,000 red blood cells, which is a little bit less than 10% of 1 year consumption in France. So very efficient. But to conclude, PBM is a must to improve patients' outcomes with numerous recent guidelines, and it could be part of ERAS programs. It needs a good coordination and a teamwork. And you have to think positive when you do implementation of such a program, and to see each patient treated as a win to achieve the total goal. Thank you very much. And I'm open for discussion and expect you at the data forum in